Hi everyone, let's see an NCLEX RN video based on infusion therapy. For better understanding of this video, kindly go through the video number 11 on fluid and electrolyte management. First question, the nurse recognizes that which patient may need infusion therapy. Select all that apply. Patient who sustained trauma presenting to the emergency department, patient with osteomyelitis receiving IV antibiotics at home, high school teacher during an annual health appraisal, patient with cancer receiving parenteral chemotherapy, patient with multiple sclerosis in remission. Look into this question. The question is asking who needs an infusion therapy. The first option, the patient who has sustained trauma. You know that trauma patient, they need fluid and blood products. So that is the answer. Then you go to the second option, patient with osteomyelitis receiving IV antibiotics at home. IV antibiotics, that patient also needs infusion therapy. Third one, high school teacher during an annual health appraisal. When health appraisal is made and if some problems are found out, immediately there is no need of an infusion. So that is not required. Patient with cancer receiving parenteral chemotherapy, parenteral related to IV therapies also. So that is the answer. Then last one, patient with multiple sclerosis in remission, they don't need infusion therapy. Second question, the nurse identifies which vein as the most appropriate for placement of a peripheral intravenous access device to begin infusion therapy. The options are dorsal hand, femoral groin, antecubital midarm, brachial upper arm. It is recommended to start therapy in the most distal available and appropriate vein and move upward with subsequent insertions. So here the most distally available is dorsal in the hand. Third one, the nurse anticipates which fluid movement when administering an isotonic IV fluid to a patient. Causes fluid to move from the cell into the intravascular space, causes fluid to move from the intravascular space into the intracellular space, causes no or equal movement of fluid into or out of the cells, causes fluid to move from the intravascular space into the interstitial space. When looking at this question, you need to know the important characteristic of IV solution, that is osmolality. That is the concentration of particles or the number of particles, that is what is osmoles per liter of the solution. You know, the normal blood and body solution, they have an osmolality of 270 to 300 milliosmoles per liter. The isotonic solutions also have the same osmolality of about 300 milliosmoles per liter. What happens is they remain in the extracellular compartment. The extracellular, that means outside the cell, that can be in the intravascular space or in the interstitial compartment. So isotonic solutions will remain there. There won't be any movement. So answer for this question is the isotonic solution causes no or equal movement of fluid into or out of the cells. We need to also know about hypotonic solution, which has lower concentration of solute. So fluid will be moving from the intravascular space into both the intracellular and interstitial space, from the intravascular space into the cells. And if you are seeing about hypertonic solutions, that their tonicity is more, that means the osmolality is more. It may be some concentration near to 600 milliosmoles per liter also. So this type of solution, when it is hypertonic solution, they move from the cell into the intravascular space. The fluid will be moving from the cell into the intravascular space. That means there is a chance of more circulatory overload, in which case in hypertonic solution. If the osmolality is more, that is if it is more than 600 milliosmoles per liter, or that is a hypertonic solution. In that case we should administer it through central venous access device. Otherwise there will be a damage to the vein. And also another important thing which you need to consider during fluid infusion is, as a nurse you should monitor the respiratory status, vital signs and skin turgor also. If elderly patients, they will be having cardiac and renal compromised things also, so there are chances they will be having fluid overload. Another thing we need to consider is the pH of the solution. If the pH of the fluid or medication, if it is less than 5 or if it is more than 9 also, there are chances that it will damage the vein, so we should administer to the central venous lines. Additionally, one more point which I'd like to add is about the antibiotics. Antibiotics having a low pH, so we should be very conscious when we are infusing antibiotics through the veins. That is the reason why the patients will be feeling signs of warmth and tenderness. There are more chances of phlebitis when we are administering antibiotics through the veins. So we should be very careful during the infusion. In order to deliver 0.9% sodium chloride at 125 ml per hour, the nurse has selected an infusion set with a drop factor of 15 drops per ml. What is the correct drop rate required to deliver this volume? 15 drops per minute, 31 drops per minute, 60 drops per minute, 125 drops per minute. This is a question which requires some calculation. For this, you need to know certain things. The answer is 31 drops per minute. I will tell you how we got it. Here, we need to first calculate ml per minute first. So here ml per hour is given, that is 125 ml per hour. This you need to convert to minutes. How many ml per minute we will be giving? That is done by 125 divided by 60. Then here the question is, you have to find out the correct drop rate. How many drops should fall in a minute? That is what drop rate is. That is the thing we need to calculate. Drops per minute is ml per minute. ml per minute is 125 by 60 into the drop factor. The drop factor is given here as 15 drops per ml. Drop factor means how many drops will make 1 ml. Different equipments or IV sets will be having different drop factors. Some openings will be small, that means bigger drops will be falling. So with minimum drops 1 ml can be made. Here 15 drops will make 1 ml. If we are taking for the pediatric patients, it is 60 drops will become 1 ml. The drop factor will be 60. So here it is 15. So to find out the drops per minute, it is 125 by 60 into 15. It is near to 31. So the answer is 31 drops per minute. A patient is ordered to receive a blood transfusion because of anemia. What is the recommended minimum gauge of the IV catheter to administer blood? 16, 18, 20 and 22. So here you need to think about the different colors and different sizes and their clinical indications of the catheters. 16 gauge catheter, it is gray in color. 14, 16, 18, these gauge catheters are used when patient had a trauma, a surgery, blood transfusion, or there is a need for rapid administration of large volumes. And 20 gauge, if you are seeing, okay, if it is 18 color, I forgot to tell, 18 color is green. Then moving to 20 gauge, it is pink in color and it is used for continuous or intermittent infusions and blood transfusion. 22 gauge, that is blue in color, that is used for continuous or intermittent infusion in small veins. And another is 24, which is yellow in color, used for children, that is continuous and intermittent infusions in fragile veins also we will use. Here the question is, the patient is receiving blood transfusion for anemia. That means it might be packed RBC. So the infusion of packed RBC, it requires 18 to 20 gauge catheter. That is recommended. And here in this option, if you are seeing 20 gauge, if it is available, that is smaller and much acceptable for blood transfusion. So the answer is 20. 16 gauge, it is larger and it is not required, and 22 is smaller, and if blood is going, cell lysis will happen, so it is not recommended. How should assessment finding of a blanched cool skin and leaking fluid at a peripheral infusion site be documented? The options are infiltration, infection, extravasation, and phlebitis. If you see the options, you understood that these all options are complications of a peripheral infusion therapy. What is phlebitis? Phlebitis is the inflammation of a vein, and infiltration occurs when a solution or medication is inadvertently, it is infused into the tissue surrounding the vein. So that is a complication. And when the solution or medication that is infiltrating is a vesicant, so vesicant means that is able to cause blisters. So an extravasation you can tell. So that is the leakage of IV fluid into the subcutaneous tissue. If you see the clinical manifestation of infiltration, it includes blanched skin, the skin is cool to touch, edema will be there, unexpected pain or burning at the insertion site or along the path of the vein, there will be pain. There will be leaking of fluid from the insertion site. So here when you see the question again, here the findings are like blanched cool skin and leaking fluid at the peripheral infusion site. That is an indication of infiltration. The nurse recognizes the prevention of which complication as the primary rationale for initiating total parenteral nutrition at a slow rate. Infection, hyperglycemia, discomfort, air embolism. So due to high concentration of dextrose in the total parenteral nutrition, so here the patient is getting total parenteral nutrition and the nurse is starting it at a very slow rate. The rationale is this dextrose will elevate the glucose level in the patient's body. The patient will go for hyperglycemia. So we need to start TPN at a very slow rate because patient's glucose and fluid tolerance both should be evaluated when we are administering the TPN. Then only we need to gradually increase it. So here hyperglycemia is the complication which we are trying to prevent by slowly infusing parenteral nutrition. The nurse recognizes or realizes which central access device has the least effect on a person's self-image. Non-tunneled percutaneous catheter, implanted chest port, tunneled catheter, and short peripheral catheter. So all these are central access devices, especially non-tunneled percutaneous catheter, implanted chest port, and tunneled catheter. Short peripheral catheter is the one which is not a central venous access device, but one among these will not cause disturbance to person's self-image, that is implanted chest ports, because they are under the skin, they are not easily seen. So they require minimal care and it will be allowing the patient to swim and bath also without any special precaution. So this is the least one which causes less self-image disturbance to the patient. Moving on, the nurse recognizes that education for patients receiving infusion therapy should include which information? Precautions for preventing infection, signs and symptoms to report, manufacturer of the intravenous access device, Purpose of the infusion therapy, calculation of infusion rates. So what education you will give to the patient who is getting an infusion therapy? Of course, how to prevent infection we need to teach them. Then what are the signs and symptoms they need to tell us, we need to teach them. Manufacturer, it is not required. The purpose, what is the reason for giving the medication? That is a right of the patient, so you need to teach them. Calculation of infusion rate, it is not required for the patient. If a hemolytic transfusion reaction is suspected, what is the nurse's priority action? Slow the transfusion and notify the provider. Stop the transfusion but maintain the infusion with 0.9% sodium chloride. Stop the transfusion and change the infusion site. Send a blood specimen for repeated blood typing. So the first thing you need to do is stop infusion of blood product. It should be done. But along with that, we should maintain the IV line in case immediate venous access is required for emergency medication. So we need to stop the transfusion but maintain the infusion with isotonic solution, especially 0.9% sodium chloride. And when you're talking about the isotonic solution, there is ringer lactate also, but since it contains calcium, there are chances there will be precipitate formations and all later on. So we will be always administering normal saline 0.9% for infusion. The nurse recognized the presence of pain, redness and streak formation at the site of peripheral IV site as what grade of phlebitis? 1, 2, 3, 4. So you need to know what is phlebitis and what are the grades of phlebitis. So you know that phlebitis, it is the inflammation of the vein. If you see the grading, you will be able to better answer this question. The answer is 3 because phlebitis clinical criteria and grades, if you see, if there is no clinical symptoms in the vein, that is 0 grade. If there is erythema, that is redness at the access site with or without pain, that means 1 is the grading. Pain at access site with erythema and sometimes edema may be present, 2 grade you will give. The pain at access site with erythema, streak formation 1, line formation, some differentiation you can see, and a palpable cord or vein, that is seen in grade 3. Pain at access site with erythema, streak formation, palpable venous cord greater than 1 centimeter in length, and sometimes purulent discharges there, means 4th grade. Here the patient is having pain and redness, that is erythema, and streak formation, that means grade 3. This is a scenario. Mr. Tom got admitted with motor vehicle accident. Upon arrival, he has tachycardia and hypotension. So motor vehicle accident has happened. Maybe the fluid or blood loss might have happened, that is why tachycardia and hypotension. 2 large bore IV catheters of 18 gauge, that is placed in the forearm. Then non-tunneled percutaneous central catheter is inserted. The patient is taken for exploratory laparotomy, and after the procedure a triple lumen central venous catheter is placed, and after 4 days of this laparotomy he has developed peritoneal abscess and requires IV antibiotics, analgesics, blood products and total parenteral nutrition. So let's see the first question. Nurse should be prepared to administer what IV fluid when Tom arrived in the emergency? The question is not in the operation theatre. When the patient is arrived in the emergency, what is the fluid the nurse need to give? 5% dextrose in RL, 5% dextrose in normal saline, 0.45% normal saline, 0.9% normal saline. So here for fluid resuscitation, we will be firstly administering isotonic solution. this is the fluid, and also you need to consider a fluid which will not develop any other actions with other things also. So here 0.9% normal saline is the isotonic solution which can be given for fluids resuscitation, and also it is the only fluid with which blood products can be administered. So this is the fluid we will be giving in emergency. Next, what is the rationale for the placement of a non-tunneled percutaneous central catheter for TOM? So, non-tunneled percutaneous catheter, central catheter, that is a type of central venous access device that is directly to the heart it is supplying. We need to think about different types of central venous access device here, that is non-tunneled percutaneous central catheters. There are tunneled catheters, there are implanted ports, then there are PICC lines. PICC means peripherally inserted central catheters are there. So what is the reason for placing this central catheter in this patient? That is the question. The options are: the catheter allows easy care of the catheter by TOM after discharge. There is a low risk of infection and other complication. TOM prefers to not have an IV in his hand. There is an urgent need for fluid and medication administration. So this non-tunneled percutaneous catheter, it can be placed quickly and it provides a large gauge catheter size for larger volume of fluid. So the answer is the patient who had underwent a motor vehicle accident, they need urgent fluid and medication administration. So that is the answer. The catheter can't be used after discharge, so the first option is wrong. The second one, there are chances of infection and complications, second is also wrong. And third one, the peripheral lines are very small. It is not that the patient has told I don't want a peripheral line. It is not like that. The nurse recognizes that multiple units of packed RBCs Tom received for blood loss after his accident did not contain clotting factors and anticipates that which blood component should be required. So the patient was getting packed RBCs, but some clotting factors were missing. So when we are administering what product, the patient will get clotting factors also. Fresh frozen plasma, granulocytes, platelets and whole blood. So fresh frozen plasma, it contains clotting factors that are not replaced when the patient receives only packed RBCs. So answer is fresh frozen plasma. In which port of his triple lumen central venous access device can the nurse infuse the next dose of antibiotic? Select all that apply. Port with the parenteral nutrition infusion, port with the packed RBC infusion, port where the patient controlled analgesics is attached, port that is saline locked, port with 0.9% normal saline infusion. So here the nurse has to give antibiotics. So if the patient is getting a parenteral nutrition infusion through one port, that is dedicated line that should not be used to infuse anything else. So here through the parenteral nutrition infusion port we cannot administer antibiotic. Second one, if blood products are given through that port also we cannot give antibiotics. But the third one, the patient controlled analgesic is attached, means that is a way. If antibiotics is compatible with the analgesic, we can infuse. We can temporarily stop the analgesic for some time and we can administer the antibiotic. Next one, port that is saline locked. Saline locked port can be used to administer antibiotics. And the third last one also, the port with 0.9% normal saline infusion. So normal saline, you know that it is the only fluid through which it won't interfere with the other products. So that is compatible. We can administer. On assessing the central line, the nurse notes that the lure lock on one of the lumens is not tight and recognizes that this places him at risk for which complication. So the options are air embolism, clotting of the catheter, infection and fluid loss. So when we see the complications of using a central venous infusion therapy, three main complications are there: infection, their loss of patency, and third one is air embolism. Air embolism occurs when air is inadvertently introduced into the venous system, and it can occur in cases like if the catheter is damaged, during the insertion of a central venous catheter, during the removal of central venous catheter, or if the connections in the intravenous delivery system, that is the catheter hub, tubing, injection cap, are not tightly secured with a lure locked connection. So at that time all air embolism will happen. So the answer is air embolism is the complication which can develop if it is not tightened with a lure locked connection. Certain nursing action can prevent the air embolism in central venous access device patients, that is proper Trendelenburg position during the central venous catheter insertion, that is 10 to 30 degree we can use during insertion. Then avoiding central venous catheter insertion during inspiration, we should avoid that. Then we should correct the hypovolemia prior to central venous catheter insertion. We should ensure that all the IV connections are intact and secure, and all lumens are capped or clamped. We should ensure, and additionally lure locking connections, frequently checking the connections, clamping the catheter and injection sites when it is not in use. These all things a nurse should do. And we can use infusion pumps and flushing, that is priming of the air out of the IV tubing and the solution. It is very much important when we are connecting fluid to the central venous catheter so that no air passes to the blood. And when we are giving the things through a syringe, expelling air out of all syringe prior to use and inspecting all the lines and connections are very much important to prevent air embolism. And when we are removing the central venous catheter, at that time the patient should be in supine position. When insertion, the patient should be in Trendelenburg position with 10 to 30 degree, and when the central venous catheter is being removed, so at that time patient should be in supine position, and also the patient should be instructed to perform Valsalva's maneuver or exhale during the removal to prevent the introduction of air into the line. And the catheter should be removed very slowly, and a sterile dressing should be placed over the insertion site, and it should be left in place for at least 24 hours. These are the points also you should be considering when we are taking care of central lines. Thank you so much. Hope you understood. Please do subscribe for more videos.